Sir KRS Sambashiva Rao Sir, Pro Vice Chancellor Vinita Kaur Saluja Ma'am, Registrar Sir Dr. Nagakishore Bhavnam Sir. For giving me this opportunity. I am delighted to welcome you to today's webinar on Arthropod Borne diseases and overview. We are honored to have with us a distinguished speaker, Professor M. Madhavi, who is the head chairperson of the Board of the Studies in the Department of Zoology and the director of Sir Ronald Ross Institute of Parasitology at Osmania University, Hyderabad. Professor M. Madhavi is a renowned expert in the field with an impressive array of accomplishments. She has an extensive publication record that includes 54 international publications, 7 national publications, 7 full-length papers in proceedings. In addition, Professor Madhavi has presented at 17 international conferences.
She is disconnected, Raju.
Thank you, Sangeeta Madam, for your introduction. Madhavi, Professor Rajesh Shukla, Head of the Department of Forensic Science. Again, welcome you, ma'am. Definitely,
Yes.
These topics are very useful for the students that participated from different part of India. So actually, the arthropods are common vector of disease. Everybody is known. So today's topics are very enlightened for the students and researchers. Thank you, ma'am. And again, welcomes to this on the behalf of Mangalayatan University. I again welcome you. Please, ma'am, continue your webinar. After the webinar, the questionnaire is platform is open for all the participants. Please keep in touch and please put off your microphone off during the session. Thank you. Please, ma'am, Madhavi.
Yeah, thank you very much. A very good morning to one and all. I thank the university. Special my thanks to my guru, Professor Sambashiva Rao sir, who has given me this excellent opportunity to present today's talk of webinar on arthropod borne diseases and overview. So arthropods form a major group of diseases vectors with mosquitoes, flies, sandflies, lice, fleas, ticks and mites, which transmit a huge number of diseases to the mankind today. So many such vectors are hematophagous, which feed on the blood at some or all stages of our life. So what is exactly happening is that today we are all with this particular arthropod diseases of viral, bacterial, parasitic, ricticial and spirochetal. Viral forms the yellow fever, encephalitis, dengue, Rift Valley fever, and bacterial is the plague. Parasitic is malaria, filariasis, leishmaniasis, and rickettsial is typhus, Q fever, and spirochetal is relapsing fever. The arthropod borne viral hemorrhagic diseases, they include acute febrile diseases with extensive external and internal hemorrhages. Usually they will be very serious and may be associated with shock and liver damage with high case of fatality. The most important of these fevers are yellow fever, dengue fever, Rift Valley fever, and West Nile fever. Even West Nile fever is also entering into our India through this eastern sister states already entered. So every day we'll be listening or we'll be seeing in the newspapers regarding the threat of this yellow fever, and we have already seen the dengue fever. So what is this yellow fever? It is a communicable arthropod borne viral hemorrhagic quarantobile acute disease of short duration and varying severity. The causative agent is yellow fever virus. So it is endemic in Africa and South America in the zone between 15 degrees north and 100 degrees south latitude of the equator, which we call it as yellow fever belt. So how Egypt is protected from yellow fever is the absence of yellow fever in the Egypt and its rarity in other areas such as Eastern Africa, despite widespread of vector Aedes aegypti, which may be due to the cross immunity from other viruses, that is dengue, West Nile, Japanese encephalitis in the population, which may be providing an ecological barrier. So what is a reservoir? It is the sylvatic or jungle yellow fever. The main reservoir in the forest area is vertebrates other than human, mainly the monkeys, and the vector is the forest monkeys. And the human has no essential role in transmitting of this yellow fever. But the sylvatic is a scientific term of referring to the diseases or pathogens which are affecting only wild animals. That is the urban yellow fever, the reservoir is the human and vector is the Aedes aegypti mosquitoes. So this is how the mosquito looks like. So the period of communicability is no man-to-man transmission. So here in my previous, you can see in this figure, this is the mosquito which is already taken the full blood meal, fresh blood meal where the abdomen is completely swollen and you can see the pinkish or red or reddish brown in color, the abdomen. So the period of communicability is no man-to-man transmission, and the blood of man is infective to mosquitoes shortly during the late incubation and during the first 3 to 5 days of the disease. In mosquitoes, after biting an infected person, there is 9 to 12 days of extrinsic period or the incubation period, and then the mosquito becomes infective all over its life. There is also a trans-ovarian transmission which may be contribute to maintenance of this particular infection. So the mode of transmission is urban yellow fever is the bite of infective female Aedes aegypti mosquitoes, and the sylvatic or the jungle yellow fever is the bite of several species of genus Hemogogus, and the incubation period is 3 to 10 days and 6 days in the international health regulation. So this is the transmission of this particular flaviviridae, and this is the cycle how it is occurring through the zoonotic virus. So the susceptibility and resistance is age and the sex, all ages and both sexes are susceptible, and the immunity where you can see the infection is followed by absolute immunity, and the second attack where you can see are unknown, and the transient or the passive, whatever we call it as the passive immunity to inborn infant of immune mother occurs for up to 6 months, and the occupation is woodcutters and the hunters. They are totally. So here you can see this is actually when the mosquito bites, the incubation period is 3 to 10 days, and the symptoms like influenza, hepatic and hemorrhagic illness, and the death is 20 to 50%. You can see the clinical features. These are all the clinical features. The mild form of this particular, the sudden onset of FHMA, the chills and the muscle pains, prostration, nausea and vomiting. Here you can see the faint signs which is a slow pulse out of proportion of elevated temperature. The jaundice is moderate early in the disease and intensified later, and albuminuria or the anuria may occur, and which henceforth goes as a leukopenia. Most of the infestations resolves after 5 to 7 days, and after a brief remission of hours to a day, some cases progress to severe form of, the different forms of this gingival bleeding, epistaxis, and the liver and the renal failure. So the fatality rate of jaundice cases may reach to 20 to 50%. So these are all the clinical features. So you can see this is the red eyes, the fever, headache, bleeding, jaundice, vomiting, back pain, muscle aches, and hepatomegaly, that is the enlargement of the liver. So what is the diagnosis? The isolation of the virus from the blood by inoculation of suckling mice or mosquito or cell culture. So ELISA are the viral antigen in the blood, and PCR is the viral genome in the blood and liver tissues. The serologic diagnosis is specific IgM in the early sera or rise in the titer of the specific antibodies. So the prevention and control is definitely the vaccine, which is 17D vaccine, and also definitely the personal protective measures. And the prevention is definitely we have to take the environmental sanitation, eradication or the control of Aedes aegypti, the anti-larval and anti-pupal measures. So when you see in the life cycle, egg, larva, pupa, and the adult stages, we have to control or eradicate the anti-larval and anti-pupal measures, anti-adult measures, and the jungle mosquitoes should be impractical. And the human protection against mosquitoes like protective clothing, bed nets, and repellents is to be used. And health education should be educated to all the areas, especially regarding the modes of transmission. And these are the individual measures for the control of mosquito bites, and specific is immunization, and active immunization is a 17D vaccine, and the darker vaccine is also there. The stamaril yellow fever vaccine is already been there, and here this is the yellow fever vaccine, which we call it as YF vaccine. So international measure, it is one of the quarantinable disease, and following measures should be done to prevent the introduction of yellow fever from endemic area, which I already showed you the yellow fever belt into the receptive areas, but the vector is present and the population is susceptible in case of Egypt. So notification within 24 hours by the governments to World Health Organization is mandatory, and a valid vaccination certificate is required for all the international travelers, including the children coming from or going to this particular endemic areas of yellow fever belt. So the validity starts 10 days after primo vaccination, and it lasts for 10 years. So the validity starts on the same day after revaccination and lasts for 10 years. If no certificate is available, traveler is isolated for 6 days from the date of leaving endemic area. If the traveler arrives before 10 days of vaccination, that is, certificate is not valid yet. So the traveler is isolated until the certificate becomes valid or until the end of international particular period, and the traveler is quarantined in mosquito-proof accommodation in the airports, which we can see in the Airport Health Organization and all the big airports. And this certificate is required by many countries, including the Egypt. So the disinfection of any aircraft leaving an endemic area for receptive area by aerosol spray of suitable insecticide shortly before departure and also on the arrival. So this is actually how the yellow fever vaccination certificate looks like, and this is the yellow fever belt. Now, coming about the next arthropod borne disease is dengue fever or braid-borne fever. So this is a communicable arthropod borne viral hemorrhagic acute febrile disease of short duration and varying severity. It is endemic in South Asia, and the dengue 1, 2, 3, 4 are now endemic in Africa. So in the recent years, outbreaks of dengue fever has occurred on the east coast of Africa from Mozambique to Ethiopia to Saudi Arabia. So this is, I have taken from Center for Disease Control, CDC, and you can see the cream color or yellowish colors are the areas which are infested with Aedes aegypti, and the red one is areas with Aedes aegypti and dengue epidemic activity. So you can see that the complete India and also the neighboring countries of India are completely immersed with the Aedes aegypti and dengue epidemic activity as per CDC, Center for Disease Control. And the causative agent is viruses of the dengue fever is 1, 2, 3, and 4 type serotypes, and the reservoir is man mosquito cycle in the tropical urban centers. A monkey mosquito cycle may severe as a reservoir in the South Asia and West Africa, and the modes of transmission is bite of infective Aedes aegypti mosquito. So this is the dengue fever, a potentially lethal disease that affects 50 million people a year, and this is how the Aedes aegypti looks, and the viruses are 4 distinct but related viruses which causes the dengue, and the recovery from one gives lifelong immunity to that particular strain, and the second infection by one of the different strains can lead to the dengue hemorrhagic fever, DHV. And here you can see the life cycle of Aedes mosquito So this is how the egg larva and the pupal stages you can see, which we have done in our laboratory. Many of my students are working on this particular disease borne, like, you know, Aedes aegypti, and also the different species of the Aedes, and also the whatever the other species which are actually neglected, like the other Aedes species also we are also working. So here you can see the dengue transmission, uninfected mosquitoes, and here the mosquito which feeds on the humans infected with the dengue virus, and the extrinsic incubation period is 8 to 10 days, and infected mosquito feeds on an uninfected human, and this is how the dengue transmission occurs. So the clinical picture, if you see, the sudden onset of the fever for 3 to 5 days and intense headache, rash, early generalized erythema and maculopapular rashes, and minor bleeding, epistaxis, gum bleeding, and petachia. So generalized bleeding and lymphadenopathy is also noticed. So the persons who are having this dengue symptoms are high fever, headache, muscle and joint pains, and the pains are so distinct that even we call it as, you know, the break bone fevers, especially in the bone regions, and the pain behind the eyes, and the rashes, many rashes on the skin, vomiting and bleeding from the mouth and the nose. So these are all the different symptoms of the dengue fever. So the manifestations of dengue virus infection, if you see without symptoms and with symptoms, so when it is with symptoms, no different from other fevers. The dengue fever with the syndrome is without hemorrhage and with unusual hemorrhages, and dengue hemorrhage fever is no shock, and dengue shock syndromes are being seen. So the prevention and control is definitely environmental sanitation and eradication and control of mosquito vector, and the environmental modification is also very important, and human protection against mosquitoes should be given, as well as the health education. So this is how even if even 1 spoon of water, 1 tablespoon of water is enough for the mosquito to complete its life cycle. So this is how it is being very, very powerful, and we are not able to control this particular mosquito borne diseases. So the chikungunya, dengue, or the Zika, which is an imported cases. So here, as per the CDC, these are all the data, and we have also published certain papers on this particular, dengue. So the Zika virus is the next one. Here you can see the Zika virus is also being completely seen on the globe, with the countries with current or the past evidence of the Zika is India completely, Indonesia, Kenya, Egypt, Angola, Brazil, and also some parts of the Mexico. So the researchers think that Zika might be behind the rise of microcephaly, but a birth defect that is associated with a small head. Here you can see the small head and incomplete brain, that is development in the newborns, which is the microcephaly. So here you can see the symptoms of microcephaly is the seizures and backward sloping. The forehead is somewhat backward sloping, and hyperactivity, small head size, and coordination becomes very difficulty, and the posture is dwarfism or short stature, and the facial distortions and delays in the speech and the movements. So the next is the Rift Valley fever. It is also a communicable arthropod borne viral zoonotic disease. It was introduced to Egypt from East and South Africa in 1977, which is causing outbreak in the animals that was transmitted to the man. The causative agent is Rift Valley fever virus, and the reservoirs are the cattle, sheep, and the goats. The mode of transmission is bite of some infective Aedes and the Culex species of mosquitoes, which are handling the diseased animals and their tissues. So if you can see that the sylvatic cycle, the domestic cycle, and the human cycles here, the sylvatic cycle, the trans-ovarial transmission is there, but whereas in the domestic cycle, that actually comes from the domestic animals, and in the human cycle, it is the zoonosis. So the Rift Valley fever, you can see the red part is the major epidemics, and the yellow one is the countries which are at risk, and the red one arrows are the extensions of this particular Rift Valley viruses. So these are all the aborted animals from the infected cows with this Rift Valley fevers and viruses. So the clinical picture is disease is usually mild and self-limited. Fever, influenza like picture and the recovery, and severe cases show hemorrhagic fever, liver necrosis, damage of the retina, and encephalitis, and it may be fatal sometimes when it is not diagnosed properly. So what is the prevention and control? The measures of animal reservoirs, the prevention and control in the animals, especially the vaccination, and the quarantine of imported animals from the endemic areas, if at all we are going to import, and the eradication or control of mosquito vector, and the measures for the man is human protection against mosquitoes. So the next is the viral encephalitis, which is an endemic disease in different parts of the world, and usually the mild but serious outbreaks have been reported with involvement of the brain, spinal cord, and meninges. So it is the occurrence of West Nile virus encephalitis in the Africa and Middle East areas, and the Eastern equine encephalitis is in the East United States of America, Western equine encephalitis in the West USA, Japanese encephalitis in Japan, Korea, and Philippines, and also our own country, India. So the West Nile virus transmission cycle, you can see, it is especially from the mosquito vector and the West Nile viruses, the birds which are acting as a reservoirs or the hosts, and this is how the transmission occurs, and incidental infections are also seen in the, the horses and some areas in the cattle. So the agent is specific arbovirus, birds and some wild and domestic animals, and mostly by the mosquitoes and some by the ticks. Ticks are also there. So in Egypt, the West Nile virus is transmitted by the culex, which is another species of mosquitoes. So what is the prevention? The eradication or the control of the vector, and the protection of the man from the vectors, and quarantine measures for imported birds and animals. So what are the other viral hemorrhagic fevers? Here they are Lassa fever, Marburg disease, and Ebola virus disease, which are highly fatal and manifested by hemorrhagic maculopapular rash and bleeding from all orifices of the body in case of Ebola virus disease. So this is also already we have seen, this is a movie that has been in 1995, that is Ebola Zombies. So the Ebola virus ecology and transmission, if you can see here, so this is also taken from Center for Disease Control. That is Ebola virus disease is a zoonotic disease. Zoonotic disease involve animals and humans. So animal to animal transmission, the evidence suggests that the bats are the reservoirs for this particular Ebola virus, and the bats carrying the viruses can transmit it to other animals, and like apes, monkeys, and the other parts of the antelopes as well as the humans. So that we call it as a animal to animal transmission. The spillover event is a spillover event which occurs when an animal, that is bat, ape, monkeys, or any other kind of antelopes, here the human becomes infected with this Ebola virus through the contact with the reservoir host, and here this contact could occur through the hunting or preparing the animal's meat for eating. So that is called as a spillover event. And human to human transmission is once the Ebola virus has infected the first human's, transmission of the virus from one human to another can occur through contact with the blood and the body fluids of sick people, or with the bodies of those who have died of this Ebola. So that is human to human transmission. And the survivors are the Ebola survivors face new challenges after recovery, and some survivors report effects such as tiredness and muscle aches, and they also can face the stigma in they re-enter this particular again in the communities. So eating the bushmeat is behind the outbreak, you can see. So this is the Ebola virus that is a typical path through the human beings. The first symptoms, headache, fatigue, fever, muscle soreness in day from 7 to 9 days, and day 10 is sudden high fever, vomiting, the vomiting the blood, passive behavior, and the day 11 is bruising, brain damage, bleeding from the nose, mouth, eyes, and the anus. Final stages very quickly by day 12 or so, the loss of consciousness and seizures, massive internal bleeding, and finally leads to death. So will Ebola ever end in Africa was actually given in 2016. And here you can see the other important disease is typhus. So the typhus is endemic tick-borne and endemic louse-borne. It is a trans-ovarial transmission. So that is the tick bites, especially from the rodents. The soft ornithodoros ticks will be biting the humans, and this is how this particular typhus disease occurs. So this is of two types: epidemic typhus, that is louse-borne typhus, and the epidemic typhus is a classical typhus. The causative agent is a Rickettsia prowsaki, and the vector is a human body louse and a human head louse also sometimes. And incubation period is 5 to 21 days. Mortality rate is 20 to 30% in the untreated cases. And the symptoms are severe headache, chills, generalized myalgia, and high fevers, vomiting, macular rash, and also lack of consciousness. The causative organism here, it is the Rickettsia prowse, as I already told you. The reservoir is man, the organisms which are found in the blood throughout the febrile stages, and the vector is a louse, that is Pediculus humanus. So the modes of transmission is contamination of the skin, especially with the feces of this particular infected louse, and the organisms they find very they find the entry through the skin abrasions by scratching and inhalation of the dried feces of the infected louse. It is again trans-ovarial transmission. The incubation period is 12 to 14 days. When you see the clinical picture, the skin rashes appears on the 5th day on the folds of the axilla, anterior part of the forearms, then trunk and the back. The complications are bronchopneumonia, thrombotic changes, and the toes and the genitalia. We can also see different complications. And the diagnosis is the lab investigations as Weilflix reaction of agglutation test. So you can see, my dear participants, so this is how it will look if it is not treated properly. So what is the prevention? The community development, health education, the personal cleanliness, and the measures against the lousiness, providing washing facilities, delousing of the population, washing facilities, and dusting with a suitable insecticide, and specific prevention of typhus vaccine and Madrid E-typhus vaccine. Single IM dose immunity, this is for 5 years. So this is how. And control is isolation in the hospitals after dusting, and treatment by tetracycline 500 mg by 6 hours for 7 days, and release after clinical recovery of the cases. So the epidemic measures is again delousing of the confined groups and underdeveloped communities by washing facilities and dustings, vaccination of high risk groups, searching for the source of infection. That was the epidemic was the first type, and the second is the endemic or the murine typhus, that is flea-borne typhus. So this is again caused by Rickettsia typhi. The rat flea is the vector here. So this is the figure which we are showing through the scanning electron microscope. And the murine typhus is an under-recognized entity, as it is often confused with a viral illness. So most people who are infected do not realize that they have been bitten by the fleas. So the reservoir of infection, as I told you, the rat, and the vector is the rat flea, and the modes of transmission is contamination of the skin with the feces of infective fleas, and organisms find entry through the skin aberrations. So the clinical picture, you can see the incubation period is 8 to 14 days, which resembles the mild epidemic typhus, and the diagnosis is again Weilflix reaction. Prevention is eradication and control of this particular rats and controls of these fleas, and no specific prevention is being seen. And you can see, so this is how the endemic typhus, if it is not treated properly, it will be like this. Next is the Q fever. The Q fever is also called as the quarry fever. Q is for quarry because when it was described, its etiology was unknown, and an acute infectious disease caused by the rickettsial organism Coxiella bruneti. It affects a variety of animals, but unlike other rickettsial disease, it is not transmitted to humans through an insect vector. So you can see that the Q fever transmitted between the animals by ticks and airborne route, and eating or contaminated meat and drinking the unpasteurized milk is also, again, we are getting this Coxiella bruneti. And the organisms which enter into the humans or the man, the organisms multiply in the respiratory tract that may spread through the blood to the liver and the heart, and the inhaling of this particular from the died excreta of the infected animals, or even handling the infected animals will also be seen. See, acute febrile rickettsial disease with minimal clinical manifestations, mainly in the form of atypical pneumonia. And the agent, as I already told you, that Coxiella bruneti, which is an organism which has unusual stability. It survives adverse physical conditions such as dryness, pasteurization, and many disinfectants. So the reservoirs are the ticks, human body lice, small wild mammals, cattle, sheep, goats, birds, and man. And the period of communicability is a direct transmission from person to person, which is also rare. So the modes of transmission is occupational, direct contact with the domestic animals, and airborne, dust contaminated by the placental tissues, birth fluids, and excreta of the infected animals, or the ingestion of raw milk, transconjunctival, and from person to person. These are all the modes of transmission. And you can see the first entry, spread, disease, and exit. The entry is aerosol from infected sheep, goats, or cattle, and the spread is hematogenous through the blood, and disease is pneumonotitis and endocarditis and granulomas. Exit is usually none in the man. And next you can see the case presentations of incubation period is 14 to 21 days, and the clinical picture is onset is sudden with chills, headache, malaise, weakness, and severe sweats. So infection may be inapparent or non-specific. Pneumatitis is found in the X-rays, and spontaneous recovery is very common. So diagnosis is culture in the X or animal inoculation from blood after onset of disease, and serological tests may show a rising titer, and Wilflix reaction is negative. So these are the control is preventive measures, health education, and immunization. So the inactivated vaccine, that is Q34, for high-risk workers as lab workers and workers in contacts with animals and animal products. So this is the QVAX. And the B, control of cases and contacts, is notifications of LHOs and isolation, of course, and the tetracycline or chloramphenicol is very effective, and disinfection concurrent of sputum, blood, and the articles. So the next one is the relapsing fever in the arthropod borne diseases. The relapsing fever, which is again an arthropod borne infection, which is caused by the ticks. So the implicated arthropod body loves the ticks are the causative organisms, and the tick-borne endemic relapsing fever, which we call it as TBRF, is a zoonosis transmitted principally from rodents to humans by the bite of various soft ticks. So louse-borne epidemic relapsing fever, which we call it as LBRF, is a disease of humans that is transmitted from one person to another by the body louse, and characterized by recurrent acute episodes of spirochetemia and fever alternating with variable periods of remission. So you can see the complete globe is being almost all immersed with a relapsing fever except Australia and Greenland. So the tick-borne relapsing fever is a systemic spirochetal disease due to the infection with the Borrelia duttonii. And here, this is how actually the tick looks before feeding, and after feeding completely bulged up with a reddish in color. And this is the transmitted by the ticks. So the Burulenia duttoni, many different strains according to areas of isolation and or vector rather than biological differences. The reservoir in most areas, it affects the rodents and accidentally in man, but in Central Africa, it primarily affects the man. So the period of communicability, ticks remains ineffective for several years and they pass the infection transovarially to their progeny. So the most of the modes of transmission is by through the saliva or coxal fluid of an infected tick. So the case presentations, if you see the incubation period is 3 to 10 days, and the periods of fever lasting is 2 to 9 days, alternating with afebrile periods of 2 to 4 days. And the transitory pectial rashes are very common. And the bronchitis, nerve pulses, hepatosphere, splenomegaly, and the renal fevers can occur. And the fatality rate is 2 to 10%. So this is how you can see on the skin. So the tick bite is approximately some 3 to 7 days. Incubation period lasts for 7 days. And the symptomatic periods or relapsing episodes approximately 3 days. And afebrile or no fever periods may also last up to 3 to 5 days. So the diagnosis is a blood films which show the circulating. So you can see these are all the circulating the Borrelia duttoni, and the prevention measures or the control measures is control of the ticks and rodents by benzene hexachloride or dieldrin to prevent the ticks from infesting the human habitations. And cracks and proper housing constructions are very, very important. And protection of susceptible, use of personal protection measures, including use of repellents and protective, clothes. And also the precautions with the blood and the body fluids, and treatments is again through the tetracycline drugs and applying the different types of insecticides to clothes and houses. The LBRF, the Laos-borne relapsing fever, it is again spirochetal disease caused by Borrelia recurrentis, and the gram-negative spirochetes, these are, and the man is the only reservoir for this LBRF, and the period of communicability is 4 to 5 days. Modes of transmission, that is through the human louse, that is the pediculus humanus, and no transovarial transmission, neither bites nor feces of the louse, which will cause this particular infection. In the case presentations, you can see IP is 2 to 10 days incubation period, whereas the skeletal and abdominal tenderness with palpable liver and the spleen, jaundice and purpura may occur, and sometimes cardiac failure, and this can be fatal. So the diagnosis is blood should be taken during the febrile period and examined by the dark ground illumination or stained blood fillings. Intraperitoneal inoculation or culture in the lab animals can be used to recover the spirochetes. And the preventive measures is delousing, protection of susceptible, and whatever the international measures that are being notified by World Health Organizations. And the next is the, you can see, in the year here, you can see 2015 Nobel Prize in Physiology or Medicine onward, that has been for the discovery regarding the novel therapies of some of the most devastating parasitic diseases like river blindness, lymphatic filariasis, elephantiasis, and malaria. The distribution of these diseases is quite similar and is collectively shown in the blue on the world map. So that is the filariasis is caused by the Bancroftian filariasis. So the Curry in 1866 and Joseph Bancroft in 1877, Sir Patrick Manson in 1877, considered as the father of medical entomology and tropical medicine. And it is endemic in many tropical and subtropical countries. You can see in the blue color, Africa, Asia, Western Pacific, and other countries of completely India is submerged. So filariasis in the Egypt, it is endemic, whereas you can see that the causative agent is a nematode, that is Ochararia bancrofti, and other long thread-like worms. They are the male is 4 centimeters and female 7 centimeters. Adult worm normally resides in the lymphatic of the infected people, and the female worms produce the microfilaria that reaches the bloodstream, which is this microfilaria is considered as the infective stage and 6 to 12 months after infection. So the microfilaria appears in the large number during the night with maximum density in the blood between 10 p.m. to 2 a.m. that is called as nocturnal periodicity. So the reservoir of infection is human with microfilaria in their blood, and the man is definitive host and mosquito is the intermediate host. And the period of communicability is humans can infect mosquito when microfilaria is present in peripheral blood, and they can persist 5 to 10 years or longer after infection, and the mosquito becomes an infective after about 2 weeks. So the modes of transmission is bite of these infective mosquitoes, the female Culex pipens or Quincifasciatus, this is another species, but it could be transmitted by the bite of Anopheles gambia and Aedes also these days. So the mosquito cycle begins when microfilaria are ingested by the female mosquitoes during the feeding. So the microfilaria penetrates into the stomach wall of the insect and develops in the thoracic muscles in elongated infective filarial form worm that migrates to the proboscis. So when mosquito bites an individual, the larvae will immediately, they can enter into the punctured skin, then passes via the lymphatic where they molt and become the adults. So this is the different mosquito species, Aedes, Culex pipens and Anopheles. You have many species in Culex, Anopheles and Aedes, as I already told you. This is how the microfilaria develops in the thoracic regions of the muscles, and you can see that the microfilaria gain access to the hemolymph and migrate to the thoracic muscles, and the productions of AMPs and the melanization and encapsulation responses are also seen in the hemocytes also. The microfilaria move through the esophagus into the blood, and the mosquito when takes the blood meal through the ingestion, the microfilaria and the larvae are infected to the host during the blood feeding. So that the third stage of the larva migrate to the head and the proboscis. So these are the routes of infection in the mosquito stages and human stages. In the mosquito stage, you can see when a mosquito that has infective larva in its blood that bites the humans, the larvae is transmitted into their body. And immediately from there it enters into the human stage where the filaria mature in the human body, and in the human stages, adult filaria, they migrate to the lymphatic vessels and gives birth to the thousands of microfilaria. And mosquito bites infected the human body and takes in the microfilaria. And microfilaria later grows into the infective larva in the mosquito's body and migrate to the proboscis. So this is the routes of infection. The filariasis, that is Wuchereria bancrofti, you can see mosquito takes a blood meal and enters into the human stages, adults in the lymphatic stages, and adults produces the sheathed microfilaria that migrate into the lymph and the blood channels. And the mosquito takes a blood meal, that is, it ingests the the microfilaria, and microfilaria shed sheaths penetrates mosquitoes mid-gut and migrate to the thoracic muscles. And then the larvae, that is this particular larvae enters into the L1 and L3 stages and migrate to the head and mosquito proboscis. So this is the filariasis, how it will takes place. The life cycle of Wuchereria bancrofti and Bruguiera malayi, that is lymphatic filariasis or elephantiasis, what we talk, the juvenile migrates to the lymph nodes which grows to the sexual maturity, and the female produces the microfilaria which end up to the bloodstream. So the vector, a mosquito ingests the microfilaria when it takes the blood meal, and immediately what it will do, the microfilaria develops into the infective juveniles in the mosquito, and the mosquito infects the infective juvenile when it feeds. So the susceptibility and resistance is the filarial disease appears only in small percentage of infected persons, and the immunity is man may develop resistance only after many years of exposure to the infection, and the environment like unsanitary planning with inadequate sewage disposal were breeding places of culex and collection of water for other species. So you can see this is how the Culex quinquefasciatus breeding sites the dirty water in the blocked drains, cesspits, pits, etc. Can you name any one area in our country where you cannot see such places? So it's become so, for us uncontrollable to control this particular mosquito-borne diseases. So the clinical feature is asymptomatic, and the acute form is fever, lymphangitis, and lymphadenitis, and the chronic obstruction form is due to the fibrosis and obstruction of lymphatic vessels after repeated attacks. So 10 years later, leading to the elephantiasis of limbs, the breast and the genitalia, and hydrocele, chyluria, paroxysmal nocturnal asthma, and severe eosinophilia. So this is how you can see, my dear colleagues, the reaction to the adult worms in the lymphatic vessels, which leads to the acute lymphangitis, filarial abscess, elephantiasis, and this is how the complete in the lungs you can see the pinkish color, tropical pulmonary eosinophilia, and lymphadenopathy is also seen. So this is how the persons who are affected with this particular elephantiasis. So the diagnosis is detection of microfilaria in the blood during maximum presence. That is, as I already told you, the nocturnal periodicity. And the live microfilaria can be seen in the drop of blood, Giemsia smears. And the prevention is environmental sanitation, eradication or control of mosquito vector, human protection against mosquitoes, protective clothing, bed nets, repellents, health education, modes of transmission, and protection against the mosquito bites. And specific mass drug administration, WHO, that is World Health Organization, recommends MDA, that is mass drug administration in endemic areas, and the annual single dose or diethyl carbamazine citrate, that is DEC, 6 mg per kg of the body weight plus 400 mg of albendazole for 4 to 6 years, or regular use of DEC medicated cooking salt for 1 to 2 years. So twofold purpose: preventing future cases of lymphatic filariasis and helping those people who are already suffering from this particular disease. So DEC plus albendazole is very, very important. To use up the common salt is medicated with 1 to 4 grams of DEC per kg. And the control is the isolation, and as far as possible, patients with microfilaria treated with antifilarial drugs should be protected from mosquitoes to reduce the transmission. And the specific triple T, that is DEC's denocoid tetrazan is the triple T results in the rapid suppression of most or all MF from the blood, but may not destroy all adult worms. So low levels of MF may reappear after triple T. So therefore, this triple T must usually be repeated in the yearly interval, and the lab follow-up should be done for treated cases. So the elimination of lymphatic filariasis, the World Health Organization has launched a global program for the elimination of lymphatic filariasis worldwide, and the elimination of this particular filariasis means a reduction of disease incidence close to zero as a result of continued and coordinated activities. Let me tell you, my dear friends, in India we have seen that we have already come to zero, but again the re-emergence of this particular lymphatic filariasis is again noticed in several parts of our Telugu speaking, that is both the Telugu states and also in some parts of the South India and also the eastern parts of the India. So to interrupt the transmission, the entire population at risk must be covered by MDA for a long period, enough to ensure that level of MF in blood remains below that which is necessary to sustain the transmission. So the global program to eliminate the lymphatic filariasis, which we call it as GPELF, by 2020, but it is already 2024, but we are not able to even to eliminate it. The elimination is nearing to zero. So the next is the leishmaniasis, which is caused by leishmania, which is transmitted by the sand flies. So the vector is several species of the sand flies, or the vectors for this leishmaniasis. And here the life cycle of leishmania parasites, you can see the promastigotes which migrates to the proboscis and are now able to transmit the disease. When an infected sandfly takes a blood meal, it infects the promastigotes into the skin of the host, and the macrophages phagocyte promastigotes that differentiate into the amastigotes and multiply in the cells of various tissues, and the macrophages burst, releasing more amastigotes that are again rephagocytized. And when an uninfected sandfly bites an infected individual, the fly it injures the amastigotes, and the amastigotes differentiates into promastigote stage and divide into the midgut of the fly. So this particular blue one is the female sandfly that is in the vector. You can see this particular life cycle, and here the orange one that takes place in the mammals or the reservoirs or the host, that is the different kinds of reservoirs what we have observed in this case of leishmania parasites. And there are many species: leishmania tropica, major, ethiopica, mexicana, all causes CL, that is cutaneous leishmaniasis, and leishmania brasiliensis causes mucocutaneous leishmaniasis, MCL, and leishmania donovani infantum and chagassi causes visceral leishmaniasis. So leishmaniasis in Egypt, actually, this was focused by in the visceral leishmaniasis, and there were many cases even till today in case of leishmaniasis in the African countries and also in the Sudan and Libya. So the cutaneous leishmaniasis is New World cutaneous leishmaniasis and Old World cutaneous leishmaniasis, and the modes of transmission is infective sandfly, which we can see in the different regions like Mexico, Peru, Central Asia, India, West Africa, and in Egypt, Alexandria region, Mediterranean, Southwest Asia, Ethiopia, and Kenya. The different species of this leishmania you can see. So this is the clinical picture, how it is starts with a papule and enlarges to become an indolent ulcer on exposed parts of the body, which either heals or lasts for many years. So the leishmania tropica, that is cutaneous leishmaniasis, both lesions are leishmaniasis only. And you can see that this is a mucocutaneous leishmaniasis. The causative agent is Leishmania brasiliensis, and nasopharyngeal destruction and deformities occurs in this particular case of mucocutaneous leishmaniasis. And this is the Leishmanias brasiliensis, that is completely, you can see that distortion in the the nasal regions. And visceral leishmaniasis, the Kala Azar, that is Leishmania donovani, chronic infection with the fever and hepatosplenomegaly, lymphadenopathy and anemia, progressive emaciation and weakness with a general fatal outcomes if it is not treated properly. And the diagnosis of leishmaniasis is demonstration of leishmania bodies in the stained smear of the ulcer organ or the blood if it is necessary. And the prevention is protection of man from the sandflies using the repellents, protective clothes, vector controls by the insecticides, proper control of domestic animals, especially dogs, very dangerous, and rodent control, and giving proper health education awareness programs. And the specific is active immunization and a live attenuated vaccine to minimize the severity of the disease in some endemic areas, and international measures has to be taken. And the control of cases and contacts is early case findings and treatments. Skin lesions must be covered to avoid the infection of vector and contact infection of exposed individuals. And health education is mandatory in these cases. And the most dreadful is the malaria. That is almost, we have come to our last arthropod borne disease, a parasitic re-emerging disease. So this is again re-emerging. 1 million deaths per year in the world, mostly young African children. As being the director of Sir Ronald Ross Institute of Parasitology, which is again a part of our Osmania University, we are all focusing, and even my major area is also control and also to try certain types of vaccines. And you know that currently government is focusing only on the till almost last year on the COVID. Now we are also able to do certain things by using certain plant products and also to control the anti-larval and anti-pupal measures. And the recently multiple foci of the drug-resistant malaria are encountered in different areas like tropical and subtropical areas. And the chance of encountering malaria here, you can see the reddish color is a highly threat countries like tropical Africa, as you all know, and Indian subcontinent and southern Eastern Asia. And the pinkish color is the southwestern Pacific. They're moderately threat, and the low threat are somewhat the cream in color. They are the other parts on the globe, as you can see. And there is the little or no threat you can see is absolutely in the United States of America, Australia, and some parts of the Russia. So the causative agent is a protozoan parasites with asexual and sexual phase of the Plasmodium vivax, Falciparum, ovale, and malaria. These are all the different species of Plasmodium, and the mixed infections are not infrequent in the endemic areas. And the reservoirs are humans, only important reservoirs of human malaria. And the cases may be several Plasmodia species at the same time, and infective stage to vector is gametocytes, which have to be mature both sexes, sufficient density, and viable. Anti-malaria drugs lose viability of gametocytes. The female anopheline mosquito is the definitive host, and the infective stage to man is the sporozoite. So this is how I told you already that only 1 tablespoon of water is enough for the mosquito to complete its life cycle. So once the mosquito enters on our body, on the skin, this is how it will be injecting through its mouth parts, like piercing and sucking type of mouth parts. It pierces and sucks the blood with like a needle-like mouth parts. And when it is taking the fresh blood meal, this is how the thorax looks like, So this is very the period of communicability is as long as the infective macrogametes are present in the blood of the patients. This varies with the parasite species. If what happens in untreated cases, it may reach up to 3 years. However, with anti-malarial drugs, the period is shortened greatly. Humans may infect mosquitoes as long as infective gametocytes are present in the blood. This varies with parasite species and with response to therapy. Untreated or insufficiently treated patients may be source of mosquito infection for 1 or several years. So the transmission may occur as long as asexual forms remain in the circulating blood. So the stored blood can remain ineffective for at least a month. So this is how the Plasmodium life cycle occurs in the erythrocytic stage and the mosquito stage. Sir Ronald Ross is the person who has discovered that the mosquito is responsible for this particular malaria. Otherwise, earlier it was what they were thinking that malaria, mala means it is a bad air, area is air. So with that bad air, we are getting this particular disease called as malaria. But no, the thing is, Sir Ronald Ross, who was a British doctor who was at our Hyderabad in the present Ronald Ross Institute, what we are, that institute where I told you already that I am the director, which is under Osmania University. There he carried out many experiments, and he has come to this conclusion that there are 2 stages, that is mosquito stage and the erythrocytic stage. And he said that the cytozoins or in the liver stages, the hepatocytes, and in the erythrocytic stages, the different merozoites, asexual stages, schizoids, trophozoites, and sexual differentiation gamocytes that occurs in the human. And in the mosquito stage, from the salivary glands, the gametocytes sporozoites, micro and the macro gametes, and this is complete the mosquito stage, the rosette stage. For this discovery, he got a Nobel Prize in the year 1902 for the great invention and the discovery that the malaria is caused by the mosquitoes, which is acting as a vector. So this is the Plasmodium life cycle, asexual stage, and the pathogenesis of the malaria. So already I told you the Plasmodium life cycle, the asexual stages in the bloodstream, asexual stages in the liver, sexual stages in the mosquito. The pathogenesis of malaria is parasite sequestration in the brain and the lungs, endothelial dysfunction, tissue inflammation. Once it enters, it will go complete in our body, the darshan of our body. It enters into the various major organs and it will infect each and every vital organ. And the bite of infective female anopheline mosquito, where the sporozoites are present in the salivary glands. Most species feed at the night. Some important vectors also bite at the dusk or in the early morning. So the infection or transfusion of the infected blood or use of contaminated needles or syringes, example, injecting the drug users may also transmit malaria. So congenital transmission occurs rarely. However, the pregnant women are vulnerable than others to falciparum malaria and possibly other Plasmodium species. So this is the malarial transmission cycle. So what happens, particularly the first infected person, liver infection, infected red blood cells, RBCs, second infected mosquito and Plasmodium gametocytes, and henceforth this malarial transmission cycle is like it is never ending. So the incubation period is time between infective bite and the appearance of the clinical symptoms, which may take from minimum is 9 and maximum is 40 days according to a type of malarial species. So based on the species, our incubation period or the appearance of the clinical symptoms will be seen. So with this infection through the blood transfusion, the incubation period depends on the number of parasites that are infused and are usually short but may range up to about 2 months. So the susceptibility is universal except in the human with the specific genetic traits, and all ages are affected. Tolerance to clinical disease is present in the adults and highly endemic areas where exposure to infective anopheline is continuous over many years. And the sex is males are more exposed usually due to outdoor life, and immunity is no natural immunity. Infection induces the species-specific immunity and some sort of active immunity develops in the endemic areas. So this is how the malaria, when it is examined under the microscope, you can see a normal cell and an infected RBC with adhesive knobs, and the malarial parasites multiply in the red blood cells. So the genetic most indigenous populations of Africa show a natural resistance to this infection with the Plasmodium vivax, which is associated with the absence of Duffy factor in their erythrocytes. So persons with this sickle cell trait, heterozoites, show relatively low parasitemia when infected with Plasmodium falciparum. So relatively protected from severe disease, homozygotes suffering from sickle cell disease are at increased risk of severe falciparum malaria, especially anemia. So the HIV infection increased risk of symptomatic falciparum malaria and its severe manifestations. Socio-cultural and environmental factors also influence, like low socio-economic standards, outdoor sleeping, agricultural societies, weighted aid contribute to the spread of infection, and the suitable environment for mosquito breeding, that is hot, humid plus rainfall. So the clinical picture is a slowly rising of the fever, chills, malaise, headache, nausea, muscle and joint pain, and rigor sensation, rapidly rising temperature ending by profuse sweating. So these are all the symptoms, and the cycle of fever is chills. Sweating is repeated either daily or every other day or every third day, or irregular according to the malaria species, as I already told you. So the relapses may occur after a period of cure without parasitemia at irregular intervals up to 5 years. So these are all the symptoms of the malaria: enlargement of the spleen, nausea, dry cough, sweating, chills, headache, fever, fatigue, pain, and also the back pain. Complications is anemia, splenomegaly, abortion, and also fetal infections. Falciparum malaria may be associated with respiratory diseases or distress, jaundice, liver failure, encephalopathy, pulmonary and cerebral edema, coma, and sometimes definitely, if not treated, death. So the diagnosis is malarial parasites are in the tick when seen in the thick blood film. So the repeated microscopic examination every 12 to 24 hours may be necessary to cover all the parasite species. So several tests have been developed, and the most promising are the rapid diagnostic tests and plasmodial antigens in the blood and the PCRs and demonstrating antibodies which appear first week or infection may persist for years, denoting past malarial infection. And the Plasmodium falciparum vivax malariae oval. This is how they look, the ring stages, the different species of Plasmodium, the shy joints, gametocytes, and these are the different testing methods: urine dip, incubation for 20 minutes. Read the results here: negative or positive, transdermal detection of malaria, hemozoins, vapor nanobubbles. And the prevention is general preventive measures of arthropod borne diseases, environmental sanitation, environmental modification, vector control and health education, elimination of the breeding sites of the mosquitoes, eradication of the larval stages by spraying the different crude oils and larvicides on water surface. This is where we are working on. Many of my students, I've got a set of more than dozen PhD students who are working on this particular eradication at the larval as well as the pupal stages by the crude or the different plant products, and destruction of the adult mosquitoes by using suitable insecticides, and human protection, screening of windows and doors using bed nets, animal barriers between the breeding places and human habitation, using protecting clothes, apply of repellents to exposed skin between the dusks, avoid going outdoors and down when anopheline mosquitoes commonly bite, and the health education is very, very important to the public at risk, who are at the risk groups and especially the travelers, and avoid taking the blood from any individual giving the history of malaria or the history of travel or resident of this particular endemic areas. And the specific measures are chemoprophylaxis for international travelers going to this particular endemic areas, and chloroquine or hydroxychloroquine 5 mg per kg per week, or chloroquine phosphate 500 grams for the average adult, and continued for 4 to 6 weeks after leaving the endemic areas. In areas with the chloroquine resistant Plasmodium falciparum, mifloquine is recommended 5 mg per kg per week for adults, and 1 to 2 weeks before travel during the stay, and 4 weeks for leaving endemic areas. And the control is early case findings by lab examination of clinically suspected persons through malarial campaigns and using anti-malarial drugs as chloroquine or mefloquine, and contact is investigation for early case findings, investigation for source of infection or exposure. So this is Malarone and also the Larium tablets. And the malaria survey, which is very, very important, that has to be taken up as a case study or even for the research studies, the field study in endemic areas to find out the magnitude of the problem, the ecological factors, what are the different abiotic and biotic factors which are favoring this particular vector, to plan for the prevention and control. The planning is very, very important. Plan the mapping. Mapping should be done to different areas to identify the water channels, the collections, cultivated lands, houses, and climatic conditions. Study the population characteristics, the age, sex, occupation, habits, etc. Study the vectors, the types of the mosquitoes, their density, species, lifespan, breeding places, resistance to different insecticides. Choose the suitable representative sample, preparation of the teamwork, equipments, and transportation facilities, investigation, clinical and lab examination, and statistical analysis to show the malariometric indices. Statistics is very, very important. And human indices is a clinic index non-specific percentage of children between 2 to 6 years who show this particular splenomegaly, that is the excluding other causes. Interpretation is below 10% of low endemicity, 10 to 25% of moderate endemicity, and 25 to 50% of hyperendemic. And parasitic index, the specific percentage of infants below 1 year showing the malaria parasites in their blood. It is most sensitive index of recent infection. Gametocytic index is percentage of those having gametocytes in their blood. And vector index is oocytic index is percentage of oocytes or ookinites in the stomach wall of female Anopheles. And sporocyte index is the percentage of female Anopheles having sporocytes in salivary glands. So this is the message on World Malaria Day. So every year from our institute, we celebrate World Malaria Day as well as World Mosquito Day. World Mosquito Day is August 20 and Malaria Day falls on April 25th every year. So malarial eradication is the highest level of disease control and aiming at elimination of reservoir of infection. And to eradicate the malaria in certain areas of 4 phases have to be done: preparatory phase, attack phase, surveillance system, and consolidation phase. In the preparatory phase, the preparation, planning, surveying to study vector and magnitude of the problem. Attack phase, complete coverage of the area by insecticides. DDT is applied twice a year during the period of malaria transmission. Surveillance system for early case findings and presumptive treatments with the chloroquine of any case with fever and complication of treatment in the positive blood film cases. And the consolidation phases is insecticides are stopped and continue with the presumptive and radical treatments. So this is how we have to eradicate, and we have every year I will be conducting many programs from our institute, from our university. The different already Professor Sambashiva Rao sir knows also that we will be doing many kind of health education programs on this particular malaria as well as other vector-borne diseases, and many national and international conferences. Very recently, in the month of December, I have conducted 3 days international conference on the occasion of centennial celebrations of our Department of Zoology. As I being the head of the department, where we have conducted in various sessions the different programs or in the sessions of scientific sessions, and also I'm again planning to conduct another international conference, most probably again in the December, which I will be sending, and I request everyone to participate and welcome to our Osmania University. Thank you very much. A special thanks to Professor Sambashiva Rao sir, who has given me this opportunity.
Thanks, Madhavi, madam.
Thank you very much, ma'am, for this very informative session. And for just a minute, I think some questionnaires is there. Sangeeta, madam,
Yes.
Just a minute. Just a minute.
Yes, please.
Is there any questions from the participants?
Maybe there no questions were posed because it is very clear for everyone. That's why there are no questions. It seems.
Yes, sir. Just a minute, sir.
Madhavi, you can withdraw the screen sharing, no? Then your
Yes,
full
sir.
screen will come.
Yes, sir. Now is it okay, sir?
No, not yet. Not yet. Just withdraw the.
Nice thing.
It's not
Is it
gone.
okay now?
It's not going. Okay, no problem.
Yeah.
Not going, I think. Maybe it's a wonderful description about the various. Now it has gone.
Yes, sir.
Description about the various arthropodic diseases and the various remedy measures, particularly on vector-borne diseases, how it has been spread in various parts of the country. It is really very good informative, I think, and our definitely the participants might have enjoyed the information, and they will be taking necessary steps. Madhavi, you have done very, though I know you are very busy and busy with other work, you have taken long time actually.
Thank you, sir. Thank you so much. Always my pleasure.
Yes, yes. So anything, questions, anyone? If no questions, I think Madhavi has urgent work also. She can be given permission to go. Vote of thanks can be taken up.
Thank you, madam. On behalf of Mangalayatan University, I would like to extend my deepest gratitude to Professor M. Madhavi for gracing today's webinar. Thank you, ma'am, for sharing knowledge with us through your perceptive presentation. I would like to express my profound gratitude to our Honorable Vice Chancellor, Sir Professor K.R.A. Sambashiva Rao, Pro Vice Chancellor, Ma'am Vinita Kaur Saluja, Registrar, Sir, for their presence in this webinar. Thanks to all professor and colleagues and all the participants who have turned up in such great number. Once again, I thank one and all present here. Thank you.
Thank you.
Okay, Madhavi.
Yes. Thank you.
Thank you.
Thank you. Thank you. Namaste.
Thank you, Namaste.